figuring this out. Thank you for the nice invitation. Hello everybody on this afternoon. So we are going to talk about AD. This is horrible, I skipped it one. Here are my disclosures. And let's go directly to the subject of atopic dermatitis. So I do not have to remember what atopic dermatitis is for you that are all distinguished dermatologists. Just go through some figures. The lifetime prevalence of atopic dermatitis in children is achieving 15 to 30%. So this is a huge part of the children will be affected by this disease. When we consider an adult patients, it's less. It's about 2 to 10%. In our experience, it's about 6 to 10%. What is maybe more scaring is that there's an increase in incidence since the 70s. So we see more and more of these patients. And this is also a very important one, the dermatitis group. So that is including seborrheic dermatitis, atopic dermatitis, and eczema, is one of the largest skin disease burdens. Okay, so it's a very important problem. Again, I do not have to remember you this. Those patients do not suffer only from skin problems. They have an impact on their lifestyle and on their mental health. And all those things together are going to have a very important impact on their quality of life. Here you see all the cytokines that are partially involved in the pathogenesis of atopic dermatitis. We see here this little protein, the JAK, but we can find the JAK1 in all those receptors. Okay, so the interleukin-4 receptor, the 31, the 4, the 13, 22, and so on. So it is a very important protein here. When we can inhibit this protein, there is an inhibition of the STAT, and finally there is a reduction in gene expression and protein building. What can this new drug, upadacitinib, can bring as in the disease of moderate to severe atopic dermatitis? There have been 4 major trials, the Measure Up 1 and 2 studies, the atopic dermatitis Up study, and Heads Up. Now these are very boring schemes. These were well performed, published in well-respected medical journals. I think we have to just to remember 2 important things. The first one is that upadacitinib met all the primary and the key secondary endpoints versus placebo in the first 3 trials. A thing that is maybe more important is that the upadacitinib study demonstrated a superiority versus dupilumab in the Heads Up study. These schemes are considering the skin clearance here, and we see a clear dose effect. When we are using the 15 milligram, we are achieving about 70% of skin clearance in the patients at week 16, and when we are using the 30 milligrams, we are achieving about 80%, easy 75 at week 16. And the same is true when we are looking at the global assessment of the disease. Again, here, the effect of this drug at week 16 is in also responding to this dose-related effect. Okay, the green line is representing the 50 milligram and the dark green line, the 30 milligram. So we see clearly a dose-responding effect. Another thing that is very important here on this slide is where the arrow is pointing. It is a very rapid onset. Those patients that are suffering from atopic dermatitis have a very rapid relief in both their skin symptoms and both pruritus. This is a very important issue compared to dupilumab, for example. Now, what is the impact on adding topical corticosteroids on the efficacy profile of upadacitinib in terms of skin clearance, itch reduction, and the time to corticosteroids, topical steroids discontinuation? Again, here in this study, we see that there is not a huge difference between giving the patient upadacitinib alone or with topical steroids, okay? Now, I think one important thing is that it is very comfortable for the patient that he can reduce the use of steroids. And the same is true when we are assessing the same issues looking at the global assessment at week 16. Another thing is we can have a drug that is working, but is it working on the long term? So what is the efficacy profile over 52 weeks, that is 1 year, with Upada in terms of skin clearance and improvement in itch? Again, here, very reassuring slides. We have here the PASI 75, and over time, on skin clearance, we have a continuous effect, okay? So there is no tapering down, there is no loss of efficacy over time. And the same is true when we are looking at EZ90. Now, when we are looking at another important manifestation of atopic dermatitis, that is the itch, again here, a very nice effect. Long maintenance of antipruritic effect. Now, we can ask ourselves, is this important for children and adults? This study is a very complicated slide, delivering a lot of information, but just remember the efficacy and on pruritus and on skin clearance is completely equal between adult patients and adolescent patients. Okay, now we can ask ourselves, how does the efficacy of upadacitinib compares with dupilumab? This is the heads-up study design. We see here that there is a group of patients receiving dupilumab and another group, upadacitinib. And after the 24 weeks, they are switching over to upadacitinib. Again, here we have the green line that is demonstrating the results of upadacitinib and the orange line for dupi. So when we are looking here at EZ75 at week 16, we see that we have a clear advantage of upadacitinib in comparison to dupilumab. When we are looking at the EZ90, the difference is even greater. And again, here for EZ100. Also, there is a better effect on the pruritus improvement compared to dupilumab. This is also an interesting slide demonstrating the incremental benefit in skin improvement. At week 16, we have about 60% incremental improvement compared to dupilumab. Now, when we are looking on the long term, at week 24, there is still a 20% improvement. Now, that is easy to explain because the efficacy of dupilumab is starting slower on, developing slower compared to upadacitinib. Okay, I think that everybody is convinced that the drug is working. Now, is it safe to use this one? That is an important thing. We have here the integrated safety analysis over 1 year, and I think there is one thing that we have to remember. Compared to the dosing schemes, we have the problem of acne in about 13% in the UPA 15 milligram, and in the 30 milligram, about 20% of the patients. My clinical experience, it is less than this. It is not a complicated acne, it is drug-induced acne, inflammatory acne. It is easy, relatively easy to manage. That is the only one that is really significant. When we are looking at the other adverse effects, that is really not statistically significant compared to baseline and placebo. Herpes zoster may be another problem. I do not know if you have the vaccination here available. We have the vaccination available, but not yet reimbursed. I think it's always worthwhile to consider this, to discuss this with your patient, because of the incidence of herpes zoster in the groups. And you see that there is an increment in incidence concerning the 15 milligram and the 30 milligram. So just remember, there is a recombinant VZV-GE vaccine available. Consider this to discuss with your patients before starting treatment with upadacitinib for atopic dermatitis. Safety profile versus dupilumab. I think here the important one was acne for upadacitinib, and the important one for dupilumab is the conjunctivitis problem. Again here, the other adverse effects concerning non-melanoma skin cancer, lymphoma, anemia, neutropenia, and all those things are really similar in both groups, so that is not a real issue in those treatments. Now, how we're going to use this for your patient under 65 years. We start with 15 or 30. Severe patient, consider high dose. A moderate patient, consider 15 milligrams. Okay? A patient with a high disease burden, as I told you previously, consider 30 milligrams. Another thing is, patients that are not so well responding to 15 milligrams, you can taper them up. Personally, I prefer to start with 15 and then taper down if it's possible. The lowest effective dose should always be considered for maintenance therapy. Over 65 years, I think it's recommended to start with 15 milligrams, but again, in my country, the number of patients over 65 years with severe atopic dermatitis is rather exceptional. So that's not a huge problem in clinical practice. Now, when we are talking about adolescents, they recommend to start with 15 milligram, but the patient has to weigh at least 30 kilos. And again here, if you have good clinical results, we can do a start and stop. So for example, a patient who is doing very well, a patient who is having no stress factors anymore because he's on holiday, whatever, you can consider to stop. And you can reassure your patient that when they start to flare up again, you can have rapid onset of good results of the treatment. This is the monitoring, routine monitoring for a patient. So at baseline, you do a blood test for liver, for tuberculosis, viral hepatitis B, and a usual hemogram. Then at 12 weeks, we check this again without TB and viral hepatitis, that is clear, and then according to your local guidelines. Just to show you two patients, I will go rather quickly here. A patient with a severe history and a long history of atopic dermatitis. We started the guy on 30 milligrams, and after 1 month, very nice results. We discussed with the patients, this is one of our first patients, and you know, you're always careful as a doctor, so we said, okay, we taper down, we try, we see what happened, and after 60 days, okay, still okay. This guy is still under 15 milligrams now for at least a year. Okay, so what is the take-home message here? We can start with 30 milligram, When you have a good clinical response, after 1 month or 2 months, you can taper down to 50 milligram and use 15 milligram for a long-term control. Another patient, again, severe patient here. You see all the body is affected by atopic dermatitis. He got all the classical treatments, methotrexate, cyclosporine, UVA treatments, even methylprednisolone, hospitalization for topical dressings, very complicated case. You see here, he was treated with dupilumab, very nice results after 2 months. Again here's his back. He was afterwards, sometimes he was very happy with the results on the skin, but then he got this problem on the eyes, the conjunctivitis. So as you may know, conjunctivitis is encountered between 1 and 20% of the cases having this problem. So the patient himself decided to stop and came back to the department to see if there's nothing else under the horizon. We started him here on UPA, 30 milligrams, and already after 1 month, we have very nice results. Again, here is back, very nice results. So, take-home message from this one is that we can change a patient who is not very well responding from DUPI to upadacitinib, or a patient who is experiencing severe conjunctivitis or other side effects. We can still improve the patient with upadacitinib. Now to close, the classic scheme for atopic dermatitis, emollients and hygienic measures. Then we go on to topical steroids for acute therapy, maintenance therapy, the calcineurin inhibitors, conventional systemics, cyclosporine, methotrexate, maybe azathioprine. Then we have the biologics, dupilumab, tralokinumab, and this is not in terms of availability, but this is in terms of efficacy. We can now add a step on the ladder using the JAK inhibitors. I thank you for your attention.